Good afternoon, all. Actually, I think I will discuss clinical assessment of multivalvular heart disease. So, I think individual topic has already covered by other fellow cardiologists. So, now I will discuss only clinical aspect where multivalvular heart disease is present, means more than two valve is involved. So multiple valvular heart disease, it is the combination of stenotic or regurgitant lesion. It occurring in two or more than two cardiac valves, and it also called as mixed valvular heart disease. So in multivalvular heart disease, hemodynamics of one valve will affect significantly influence those of the others. So the proximal lesion influence the hemodynamic of the distal lesion, and reverse also important. So in multivalvular heart disease, clinically it is the little bit tricky and difficult to explain which valve involvement is predominant, especially for a post-graduation student and especially for practical examination. This is very much useful and very much important, where we have to decide which valve disease is prominent or predominantly present over the others. So first I will discuss in between aortic stenosis versus mitral stenosis. So if patient present with a combined lesion of aortic stenosis plus mitral stenosis, so how to decide which valve is prominent? First, mitral stenosis. In mitral stenosis, basic main problem is there is a diastolic pressure gradient from left atrium to left ventricle. So in presence of significant aortic stenosis with mitral stenosis, LV relaxation is impaired and LV diastolic pressure is likely to be elevated, thereby it attenuating the transmitral gradient, and thus isovolumetric relaxation time is also prolonged. So the issue because of that is first isovolumetric relaxation time. The isovolumetric relaxation time is period from the end of systole, which represents A2 in mitral stenosis to the opening of mitral valve, which is representing OS in mitral stenosis. So in severe aortic stenosis, the IVRT is getting prolonged, and hence the A2 OS interval can become longer, and the transmitral flow time, which is represented by mitral mid-diastolic murmur, can be shorter. So that's why if mitral stenosis is present with significant aortic stenosis, there is a under-assessment of severity of mitral stenosis can possible, because of it affects the IVRT and transmitral gradient. So it is very difficult, or we can't properly assess by A2OS interval or mitral mid-diastolic murmur. Second is in severe aortic stenosis, the left ventricular diastolic pressure gets elevated. So this results in reduction in the transmitral diastolic gradient, and that's why it reduces the intensity of mitral diastolic murmur. So again, with mitral mid-diastolic murmur, we can under-assess the severity of mitral stenosis in presence of severe aortic stenosis. Third is elevated LV end diastolic pressure in presence of severe AS. It interferes with the left atrial emptying, and which cause elevated left atrial pressure, and which further aggravate the pulmonary pressure and congestion. So ultimately, in presence of significant AS in patient with mitral stenosis, the symptoms of mitral stenosis get exaggerated with attenuation of the auscultatory finding. So hemodynamics of mitral stenosis not significantly alter the aortic stenosis, but aortic stenosis definitely alter the hemodynamics of mitral stenosis. If mitral stenosis is severe and it produces pulmonary arterial hypertension or congestive cardiac failure, then it causes lower cardiac output, which attenuates the transaortic gradient and auscultatory finding of aortic stenosis. So with low cardiac output, it exaggerates the symptoms of aortic stenosis, because there is already aortic stenosis, and again low cardiac output means it causes more exaggeration of the aortic stenosis symptoms. S4 is an important finding in severe aortic stenosis, which is absent in presence of mitral stenosis. So it is very difficult to decide which valve lesion is predominant during especially during the practical examination for student. So for that we need to differentiate and we have to correlate with symptoms as well as some clinical findings, which valve is predominant. So if we consider aortic stenosis, there should be a history of effort angina or syncope, slow rising pulse, heaving apex beat, and late picking mid-systolic murmur in aortic area. If this type of symptoms plus sign is present, then we can say aortic stenosis is more predominant compared to mitral stenosis. And if mitral stenosis is more predominant, then it should be a history-wise paroxysmal nocturnal dyspnea should be there, and tapping apex may be there. So this is the gross difference, and by this we can differentiate between which lesion is more prominent, either aortic stenosis or mitral stenosis in patient with combined AS plus MS disease. Second lesion is aortic stenosis versus mitral regurgitation. So if patient presents with both aortic stenosis as well as mitral regurgitation, how to differentiate? So as the hemodynamics abnormality in both these lesions are in systole, so one lesion can influence the other. In aortic stenosis, LV systolic pressure is elevated, hence left ventricle to left atrial systolic gradient for mitral regurgitation exaggerated. So it aggravates the symptoms and signs of mitral regurgitation. And again, regurgitation fraction increases and the forward stroke volume comes down. Hence, in presence of aortic stenosis, mitral regurgitation findings is accentuated, as we'll see below. So if we see the pulse, so pulse volume becomes lower, but character is unaltered because of aortic stenosis in patient of mitral regurgitation. With presence of AS, apex is more sustained. Because if we see in mitral regurgitation, apex beat is generally hyperdynamic, but if presence of AS is there, apex is more sustained. Then effect on second heart sound. In mitral regurgitation, there is a early A2, and in aortic stenosis, there is a delayed in A2. So we can see paradoxical split present in if aortic stenosis is significant. And if aortic stenosis is significant, we can hear fourth heart sound, S4. And mitral regurgitation murmur is also attenuated. So if we consider echo-wise, MR finding is exaggerated and a reduction in LV to aorta gradient in presence of aortic stenosis in patient with mitral regurgitation. So this is the differentiating features where both lesion is present, then which lesion is predominant. So if we see if this finding is there, like low volume, slow rising pulse, heaving apex beat, no or minimal cardiomegaly, paradoxical split of second heart sound, there is a presence of fourth heart sound or late peaking ejection systolic murmur, then this type of patients having AS more predominant compared to mitral regurgitation. And if patient is having low volume but quick rising pulse, there is a cardiomegaly, hyperdynamic apex, or wide split second heart sound, or presence of S3 or atrial fibrillation, then in this type of patients, mitral regurgitation is more predominant compared to aortic stenosis. Third one is aortic regurgitation versus mitral stenosis. So if patient comes with this both lesion, aortic regurgitation plus mitral stenosis, then how to differentiate? So hemodynamics of aortic regurgitation not significantly altered by mitral stenosis unless there is a severe pulmonary arterial hypertension or heart failure where aortic regurgitation findings are attenuated. So auscultatory finding of mitral stenosis can be attenuated by severe aortic regurgitation, as the elevated LV diastolic pressure can reduce the transmitral gradient. So assessment of severity of mitral stenosis by pressure half time modified by aortic regurgitation in echocardiography. So how to decide which lesion is predominant in this combined lesion? So if we can see if opening snap is there, loud first heart sound is there, if apical diastolic thrill is there, then there is a long loud mid diastolic murmur with presystolic accentuation is there, and finding of pulmonary arterial hypertension or chronic severe pulmonary venous hypertension is there, presence of atrial fibrillation, then history wise paroxysmal nocturnal dyspnea, and there is a absent cardiomegaly. So this type of feature suggestive of mitral stenosis more predominant over aortic regurgitation in combined lesion patients. And if we see there is a more peripheral signs of aortic regurgitation, cardiomegaly, and early peaking, mid systolic ejection, systolic murmur, then in this type of patients aortic regurgitation is more predominant in combined lesion. Fourth one is aortic regurgitation versus mitral regurgitation. So if patient presents with both these combined lesion, AR with MR, then how to decide which valve is predominant? So in aortic regurgitation, LV systolic pressure is high and hence the mitral regurgitation gets exaggerated. So because of regurgitation of blood into the left atrium during systole, the forward stroke volume into the aorta is reduced, thereby producing systolic decapitation of the blood pressure. So however, diastolic blood pressure and pulse character of aortic regurgitation not modified by mitral regurgitation. And effect on second heart sound, because of aortic regurgitation, there is a delay of aortic component of the second heart sound, delayed A2, and in mitral regurgitation it is early A2. Then murmur, in mitral regurgitation murmur is accentuated, but AR murmur is unaltered. And echo-wise finding of mitral regurgitation is exaggerated in presence of AR, while AR finding are not modified by mitral regurgitation. And if we have considered how to differentiate which lesion is prominent, then if patient having peripheral signs of AR, early peaking, mid systolic ejection murmur, and long early diastolic murmur, then this type of patients having AR more predominant over mitral regurgitation. And if patient is having wide split second heart sound, presence of third heart sound, or atrial fibrillation, which suggests mitral regurgitation is more predominant over the aortic regurgitation. Fifth lesion is mitral stenosis versus mitral regurgitation. So if patient presents with both MS plus MR, then how to decide which lesion is more severe, MS or mitral regurgitation? So mitral regurgitation plus mitral stenosis, it is the commonest combined lesion in rheumatic heart disease patient, and usually one lesion dominates. Severe stenosis and severe regurgitation cannot coexist. So because of that, we have to decide which lesion is more predominant. Mitral stenosis does not influence the hemodynamics and clinical findings of mitral regurgitation, but mitral regurgitation can enhance the finding of mitral stenosis. So the increase in left atrium volume due to mitral regurgitation elevates the left atrial pressure, hence exaggerated the clinical and echo finding of mitral stenosis. Sometimes it is difficult to diagnose mitral stenosis in severe mitral regurgitation, as we can get mid-diastolic flow murmur in severe mitral regurgitation also. So it is very difficult to decide whether just severe mitral regurgitation is present or mitral regurgitation plus mitral stenosis is present. And LV S3 of mitral regurgitation also confused with an opening snap, though the pitch of both sounds are different. So it is very difficult to differentiate between whether it is LV S3 is present or opening snap of mitral stenosis is present. So if loud first heart sound is there, diastolic thrill is there, and presystolic accentuation of murmur is there, that favors there is a presence of mitral stenosis in patients of mitral regurgitation also. Whereas in rheumatic severe isolated mitral regurgitation, first heart sound is usually soft and the flow rumble is decrescendo, one can confine to mid diastolic. So if it is because of just isolated mitral regurgitation, then first out sound should be soft, and floor rumble is decrescendo type. So to differentiate if MS plus MR is present or only severe MR is present, this is the important findings. History of paroxysmal nocturnal dyspnea should be there, and long MDM should be there, and associated diastolic thrill, loud first start sound should be there. So it can differentiate that there is a presence of MS is also there in patient with significant MR. And in MR, if cardiomegaly of left ventricle type is there, then we can say MR is more predominant over mitral stenosis, because in mitral stenosis we can't get cardiomegaly. And third heart sound will not be audible even in presence of severe MR if it is associated with at least moderate to severe mitral stenosis. Now, aortic stenosis versus aortic regurgitation. So if both lesion is present in one patient, like aortic stenosis with AR, so which is the more predominant lesion? A common dilemma in examination is the diagnosis of aortic stenosis in patient with severe aortic regurgitation, as the aortic regurgitation can produce a systolic murmur in the aortic area, which may be conducted to the carotids. So it is very difficult to decide whether it is just isolated severe AR is there or AR plus AS is there. A significant aortic gradient also will be there in severe aortic regurgitation patients. So systolic decapitation of BP, slow upstroke of carotid pulse, and systolic thrill and long systolic murmur with late systolic peaking favors the associated aortic stenosis. If this type of feature is also present in patient with AR, then we can differentiate this type of patient having AS plus AR. Then this is the differentiating features by which we can consider whether significant aortic stenosis is there or significant or predominant aortic regurgitation is there. So if history of effort angina or syncope is there, if low volume slow rising pulse is there, heaving apex beat, presence of fourth heart sound, and late peaking mid systolic murmur at aortic area present, then we can say there is a significant aortic stenosis is also present in patient with aortic regurgitation. And if patient having more of peripheral signs of AR and high volume pulse, LV type of cardiomegaly, early peaking mid systolic murmur, presence of Austin Flint murmur, or long EDM, then this type of patients having predominant AR over the aortic stenosis. Then influence of tricuspid valve disease in other lesion. So basically tricuspid valve disease having both stenosis or regurgitation, this both lesion can reduce the right ventricular output to the pulmonary circulation, and which results in reduction in the left heart volume. So this leads to affect the various other valvular disease, like if presence of any tricuspid valve disease which cause reduction in the left atrial volume and pressure, so partial relief of pulmonary congestion symptoms, the murmur of mitral stenosis becomes shorter and A to OS interval become lengthens. So the transmitral gradient also decrease. Thus the severity of mitral stenosis is likely to be underassessed if it is presents with associated tricuspid valve disease. And the reduction in the LV preload due to tricuspid valve lesion, which cause fall in LV stroke volume and cardiac output. So it exaggerated the symptoms of aortic stenosis, and the pulse volume become still lower. Thus the AS severity is overestimated in the presence of associated tricuspid valve disease. However, AS murmur will be relatively short, and in associated with tricuspid valve disease, AR is underestimated. So this is in conclusion, we can say if cardiomegaly is present, then either mitral regurgitation or aortic regurgitation should be there. In that patient, if peripheral signs of AR is more predominant, then we can say AR is more predominant over mitral regurgitation. And if wide split S2 is there, then mitral regurgitation is more predominant. If patient presents with PND with cardiomegaly, without cardiomegaly, sorry, then it is having more of mitral stenosis. If long mid diastolic murmur is there, then again it is suggestive of predominant mitral stenosis. If patient having slow rising low volume pulse, then it suggests significant aortic stenosis. Heaving apex without cardiomegaly again suggestive of significant aortic stenosis, and late peaking mid systolic murmur again suggestive of aortic stenosis significantly. So this is the all about mixed and multiple valvular heart disease, where we can clinically decide which valve is predominant over others. And this is some few questions. Which of the following is not useful to assess the severity of mitral stenosis in presence of aortic stenosis? So here we can say the length of mid diastolic murmur, because in presence of aortic stenosis, IVRT is getting prolonged, and because of that, length of MDM is also affected. So by length of MDM, we cannot decide the severity of mitral stenosis if it is presented with aortic stenosis. One more question is, which of the following indicates the predominant aortic stenosis? Cardiomegaly, wide split second heart sound, presence of AF, or presence of S4. So here we can say presence of S4 can clearly tells us about the severity of predominant AS is there, because in AS there is no cardiomegaly. In AS wide split S2 is not there and AF is not present. Then which of the following suggests the dominant AR in patient with AR with MS? Peripheral signs, cardiomegaly, early peaking mid systolic ejection systolic murmur, or all of the above. So I think it is all of the above features which suggest predominant AR in patient with AR with mitral stenosis. Then which of the following is correct in patient with mitral regurgitation plus aortic regurgitation? In aortic regurgitation, LV systolic pressure is high, and hence the mitral regurgitation gets exaggerated. So that is the correct statement, because in AR there is a not early A2, it is delayed A2, and in MR murmur is altered in presence of AR, not AR murmur. And in diastolic BP and pulse character of AR is not modified by mitral regurgitation. It is only systolic pressure which can be modified. So is the big. And which of the following features suggestive of dominant AS in patient with AR plus AS? Heaving apex, high volume pulse, cardiomegaly of LV type, or Austin Flint murmur. So it is heaving apex, which is suggestive of dominant aortic stenosis in patient with AR plus AS. Thank you, sir.
Yeah, congrats, Tushar. You discussed very beautifully, and you focused only on points. Every sentence is it's only exam point. Every point, and you have really discussed very important points. Actually, no one can escape these points in the examination, because combined valvular lesions, many times they will ask which is the dominant valve, and your narration and your description is also very beautiful. Thank you for joining. And without further ado, Vijay Kumar, are you there? Dr. Vijay Kumar Reddy? Okay, then we'll move on to the next topic.